Good evening, everybody. Welcome to this another session of 50-second comprehensive course on echocardiography. We have come a long way. We've finished with the basics, moved on to valvular diseases, and now starting with another subject that is CAD and cardiomyopathies. Well, today they take a really large amount of practice just developed on CAD and cardiomyopathies. Well, I'm Dr. Rakesh Gupta from Jorop Institute of Echocardiography, dealing with this particular topic as on today. And on top of that, the most important part is we are in this training program since April 2000 when we did our first program. And this is the 24th September, we started with a 50-second comprehensive course in echocardiography. I would like you to listen to one of the views of this particular faculty from Calcutta. She is going to take up your diastology in the due course of time.
Sir, there is no audio.
All right, let's move on. Like if there's no audio, we'll move on to the next topic. All right. So, well, we are dealing with the 14th session as on today on 24th December 2025. And this is the last session of this particular year of 2025. We are going to talk about concept of a wall motion abnormalities. That's the most important thing is. And in dealing with this concept of wall motion abnormalities, all of us understand we try to tell you what exactly these whatever we call of wall thickening abnormalities, wall motion abnormalities, or the abnormalities of the myocardiums. Let's switch on my gears to a different topic. That's exactly a concept of wall motions. I'll be very slow and just keep on writing your questions, which you're going to ask me at the end of this particular session. Now, the first important thing is in concept of wall motion abnormalities, I always say these words. The course of learning wall thickening abnormalities or wall motion abnormalities and coronary artery supply is cluttered with obstacles. It's up to you to decide if they are stumbling blocks or stepping stones. Why did I say this? Because to appreciate any wall thickening abnormalities, we have to read about 300 cases along with somebody, and then you start reporting your cases with the help of somebody. Well, the prime function of the heart is what? To pump up blood to the whole of the body from left ventricular to the systemic circulation in the right ventricular to the lungs. So what we are going to look at is, we're going to look at the left ventricular function. And in order to understand this particular phenomena, we need to understand what is the endocardium and what is the systolic thickening is. This question can be amply said by this particular slide, which tells you like how much my endocardium is thickening. Look, this is endocardium, which you see over. This is all myocardium. We are not looking at the thickening of a myocardium. We are looking at the thickening of endocardium. And that is the most important thing for any thickening of the endocardium is, look, this particular segment is thickening. Otherwise, this myocardium is showing a sliding motion. This is like four-chamber view. All of us read about this. Lateral papillary muscle, LV, LA, RA, RV. And this four-chamber view, we look at the septum, we look at the lateral wall. I still believe in 16-segment model. Then we move on to two-chamber view. In this two-chamber view, this becomes anterior wall and this becomes inferior wall. And inferior wall has got a papillary muscles. As previously, when we said the lateral wall has got a papillary muscles, now the inferior wall has got a papillary muscle, and this is whole of the anterior wall, and this is inferior wall. And when we rotate counterclockwise, further, this becomes anterior septum, and this becomes posterior wall, and it does not have a papillary muscles. If it shows you a papillary muscle, it means that patient is not looking at the posterior wall. We are looking at the inferior wall of the patients. Now the concept is, what is normokinesis? What is hypokinesis? What is akinesis? What is dyskinesis? What is hyperkinesia? And what is aneurysm? And what is persistent dilatation during diastole? Let's start one by one. This is a slide which is available for more than 25 years in systemic circulations. Systemic means in computer circulation for teaching echo. I've modified the slide according to your requirements. Like normal thickening is more than 50% of existing endocardium. If it's between 20 to 50%, it is hypokinesis. If hardly contracts, it is akinesis. If it bulges out during systole, it is known as dyskinesis. And the dyskinesis bulges remains during diastole, that is known as aneurysm. And a scarred word is where the segment becomes thinned out, hyperechoic, and measures less than 6 millimeter in dimensions. And this thinned out, hyperechoic, scarred segment does not have any contractile functions. Now, I'll go back to your previous slides. Now look how much this endocardium is thickening. That is the most important thing for any of these presentations. Let me just show you a different way again. Now you can see very well the clarity of contraction. This is all thickening which is happening in the endocardium. And that's what we need to realize every time when we are looking for wall thickening abnormalities. I'll try to show you a number of examples for this. Before I go ahead further, we need to look at what is wall motion score index. It means if we give one number to a normokinetic segments, we give two number to hypokinetic segments, we give three number to akinetic segments, we give four number to dyskinetic segments, and we give aneurysm of 5 points or numbers. Now, I've seen an example for LED, four-chamber view, apical septum, apical lateral, along with the apex. So, two segments. Two-chamber view, apical inferior, apical anterior, mid-anterior. There are three segments. Then three-chamber view, mid-anterior septum, along with apex. 3 plus 2 plus 1, 6. And akinetic means 3. So, 6 of these segments are multiplied by 3 to give you 18 number. What are the segments left behind? 10. 10 into 1 gives you 10 numbers. 28 plus 10, 28. 18 plus 10 is 28. Divided by 16 segment, that gives you wall motion score index. Now you'll realize, higher the wall motion score index, poor is the outcome. It means if your score is 1, you are happy. If it's going more than 1, you start becoming unhappy over a period of time. Now look at this segment very carefully. Now in this segment, it'll keep on playing again and again. Till this part, this is mid, this is basal, septum. It is hyperechoic. Look at this apical septum. apical lateral wall, then mid lateral wall and basal lateral wall. Now I'll play this segment again for you. This segment is hardly thickening. There's no endocardial thickening at all. There's some amount of endocardial thickening which is seen over here. Let's see back again. You can appreciate there's no thickening over here. There's no thickening. There's some amount of thickening over here. And this appears to be normally contracting. Now see back again. Because this is the most important thing is. Now this segment is thickening. This is hypoechoic, hypokinetic. This is akinetic. Now this is normally contracting. The lower basal lateral wall is some kind of a hypokinesis. Not much. But the most important part is look at this segment, which is almost akinetic hyperechoic. The echogenicity of this particular segment is much more than the echogenicity of this apical septum, apical lateral, mid and basal lateral walls. And that is what mean by akinetic segments. Another example, look at this apex. Let me just zoom it for you. Now, this segment is almost less contracting or partially contracting. Some amount of endocardial thickening you can see over here. And this segment is almost akinetic. Can you see this? So whole of the lateral wall is fine. Apical septum is fine. Mid septum is fine. But the some amount of thickness as well hypokinetic basal septum. Now in this segment, this is normokinetic. This is dyskinetic. Let me just show you how do we look at dyskinetic in full view. Concentrate on this part. With contraction, this segment is going out. Apex is going out. It's bulging out. That is dyskinetic. Let's have one more example for dyskinetic. Now, if you look carefully, this is all akinetic segments thinned out. Apex is bulging out with every systole. Correct? Now, another example for aneurysm. This is persistent dilatation during diastole. And this is what you need to appreciate always when you're looking for a wall thickening abnormality. Now, this segment is already dilated, whether diastole or systole. This is inferior wall, despite being three-chamber view. This is anterior septum. This is mid and basal inferior wall, and this apex is almost dilated. And You will see a better example from this slide. Now look at this akinetic. This is two-chamber view. No, it's not two-chamber view because we see a lateral wall over here with the papillary muscles. So it's a four-chamber view, and this is what is almost akinetic over here. This is two-chamber view and some modified over here, and this is almost akinetic. Now look at the three-chamber view on the same patient. There's no endocardial thickness over here. This looks to be contracting very well. This looks to be contracting very well. And this is basal posterior wall, circumflex territory. If I put these three pictures together, let's see this four-chamber view. Now look carefully. The septum is contracting, apex is contracting, apical lateral wall is contracting, mid and basal lateral wall, they are not contracting at all. They are thinned out, hyperechoic. Then on top of that, mid and basal inferior wall is not contracting, is hyperechoic, thinned out. So we have mid and basal inferior wall, mid and basal posterior wall, mid and basal lateral wall. Most probably we are dealing with akinetic circumflex territory. Before I go further, there are two words which we'll be talking about again and again. One is tardokinesis. What is tardokinesis? Is delayed contraction. Second is tethering effect. Tethering means a normally contracting segment adjacent to ischemic area shows reduced thickening. Why? Because the ischemic area will pull this normally contracting segments. On the contrary, it is also true. If you have a hyperkinetic muscles, may pull the ischemic segment to show it as a normal segment. So you may have the masking of ischemic zones. Just remember these words, tardokinesis as well as tethering word. Then comes aneurysm again, persistent dilatation during diastole. That is diastolic contour abnormality associated with akinesis or dyskinesis. Now this see example very clearly. This is accessory band. And look at this bulged out complete apical segments. Now see this again. There is no contraction. This is akinetic segment which is really bulged out. And this is known as aneurysmal segment or true aneurysm. Some more examples. Now you can see this is all aneurysmal. Now you can realize it better. Aneurysmal. And now you realize in four-chamber view, aneurysmal segment. And how does it look at in ECG? Persistent ST elevation in ECG. Now there's no doubt about it. This is ballooned out. Normally LV is bullet shaped, like apex is smaller in size. Here the apex is as good as a rounded shape in size. And whenever we have an aneurysmal segments or akinetic segments, there are very high chances of formation of thrombus. This is what is tardokinesis. We don't look at the tardokinesis by routine eyes. We look at the tardokinesis by doing a strain rate imaging. Every segment is displayed over here. Like this is basal septum, mid septum, apical septum, apical lateral, mid lateral, basal lateral wall. And if you look carefully, this is green, yellow color, blue, green, pink, blue, and red in color. So every color is depicted over here. If you look carefully, here is the red color. So this is red color is, it means it is talking of basal lateral wall. And this is aortic valve closure. So all of the segments, they are thickening at the time of aortic valve closure. That is known as tardokinesis. And some segment may be delayed thickening later on than the aortic valve closure. Look, this is the segment which is first relaxation, then delayed contraction, that is suggestive of Tardokinesis, and this is sometimes a word for ischemia. Look, this segment has contracted before aortic valve closure. Tethering effect. Where we'll see a tethering effect? When hypercontractile segments will affect affected segments and show almost a normal motion. Now look very carefully. This segment is hypercontractile. This segment is hypercontractile. This will try to pull this akinetic segment to make it hypokinetic. That's what is tethering effect. Now next very important question is, what does we see in acute MIs? Well, we see the same thing what we see in other things. Only fact in acute MI is we have a preserved endocardial thickness. Look, this is a patient with acute anterior wall MI. This endocardial wall is thickened, thickness is preserved. And if you happen to see a patient with acute or a chronic MI, chronic coronary disease with preserved endocardial thickness, it means that segment is almost viable and it may recover to normal after interventions. That's what I mean by acute MI. Now, like same patient, anterior wall MI, look, this segment is hypokinetic, but has got a preserved endocardial thickness. Now you can see endocardial thickness right over here. You can see a better endocardial thickness in anterior wall over here. Then apart from this ischemic wall motion abnormalities, the two things, or maybe three, two at least at your level, which will make a difference in wall thickening abnormalities. One is LBB, second is RBB. Now look at this segment in LBB. Let me just make it full chamber. Look carefully. The endocardium is well preserved. Anterior septum, and this is inferior wall, not a posterior wall. And they're thickening, but thickening over a period of delayed interval. This is what is left bundle branch block in a patient who has got diabetes presented with LBB, and we want to understand whether this patient has got some associated lesion or not. How do we differentiate? LBB will affect what? Septum. And if you happen to see anterior wall which is contracting normally, it means that patient does not have any significant coronary disease. Look at the same patient. Now this anterior wall is very well contracting. And if you see anterior wall is contracting very well, it means the patient does not have any significant coronary disease. If we acute anterior wall MI along with LBB, obviously this anterior wall will get affected. Next is RBB. RBB also virtually present like this. It only gives you a something like this kind of a patterns, not of a significant value except in certain conditions. Then there is a word which is known as dysynergy. Dysynergy means how much it is contracting. At what time it's contracting, that's another issue. So synergy is how much it's contracting. Synchrony is at what time it's contracting. And they have a lot of values in cases of cardiomyopathies. Synergy will give you the ejection fraction. Synchronicity will give you whether the segments they are contracting at the same time or not. And that's what is utilized in cardiology practice of echocardiography, looking at synchronicity as well as synergy. Some things of historic values like B colors, then automatic edge detection. This is what is known as B colors. Our eyes are not tuned to gray color to a large extent. But once they see a blue color, a gray B scan colors, this is what is seen in this subset of population. You see a better endocardial delineations. Every machine has got this. It's not a rocket science for a big machines, small machine even. Then next is tissue harmonic imaging. Look carefully. This is fundamental imaging. This is tissue harmonic imaging. We can see the endocardial delineation when we see the harmonic imaging. Here we cannot see the apex very clearly. So whenever you buy a machine with harmonic imaging. And today is not a time of alone harmonic imaging. We are talking of matrix crystal transducer. Then myocardial contrast echo. Whenever we don't see a good endocardial thickness of obese subjects, we always use myocardial contrast echo. This is automatic edge detection. It came in somewhere in 2000 and disappeared quickly. This is color kinesis, talking of how much endocardial thickness is happening. They're all qualitative. So, in two dimensions echo is backbone for assessment of wall motion abnormalities. And we have ejection fraction, which is the magic word in echo. Everybody talks, what is my ejection fraction, man? And this ejection fraction has to be done by doing biplane modified Simpson's method. We have done it I showed you from our lab. This is modified biplane Simpson. This is diastole, and systole. This is end-diastolic, end-systolic, end-diastolic, and systolic. It takes you in form of at least two chambers. And every segment is divided to diskettes to give you exact ejection fractions. Values, more than 52 males, more than 54 females. And this was one paper published in JS 2019 talking of revising the index values for ejection fraction from 52, 54 to 57 and 58. Now yet to be implemented in guidelines. Now comes coronary artery blood supply. We have seen this number of times. We are going to repeat it again and again. And now, if you look at 4-chamber, 3-chamber, 2 chambers, this is 4-chamber, 2-chamber, 3-chamber. Median basal septum, median basal inferior wall, RCA. Median basal lateral wall, median basal posterior wall, circumflex. Rest all apical septum, apical lateral, apical inferior, apical anterior, mid anterior, basal anterior, mid anterior septum, basal anterior septum. All of 8 segments are supplied by LAD territory. And once we look at this LAD territory in bullseye format, look how much big categories supplying to. Another very important part of this category supply is, look at why we say basal like lesion is a basal, a proximal LAD lesion, mid LAD lesion, or distal LAD lesion. If we have a D1 branch of LAD supplying the mid anterior basal anterior septum, this is proximal lesions. This is D2 and this is D3 and apex. If we have basal anterior septum is spared or mid anterior septum is spared, then we talk of distal LAD lesion. And this is very, very important when we do management issues. And this is how I always say, I always tell you to remember median basal septum, median basal inferior wall, RCA, RCA, RCA. Median basal lateral wall, median basal posterior wall, circumflex, circumflex, circumflex. Rest all LED, LED, LED. Now from 16, we moved on to 17 segment model. I told you last time also why we started talking of 17 segments. It's just a change of nomenclature. What we started doing it, we wanted to match with nuclear scanning images. It's not a big thing. What we look at is we looked at anterior and inferior, anterolateral, infroseptal, anteroseptal, infrolateral. So if you cut your heart in the anterior inferior wall, what we are getting this was previously the inferior wall and this was previously the anterior wall. This becomes apical inferior, this becomes mid inferior, this becomes basal inferior. This becomes apical anterior, this becomes mid interior, this becomes basal anterior. So no change as far as two segment model is concerned. Now this was somewhere it was what? Septum. So anterior and septum became anteroseptal. So when we cut in three chamber view, this septum becomes anteroseptal now. So we were talking of apical septum, mid anteroseptal and basal anteroseptal. Look, anterior and septum, we became anteroseptal. And between inferior and lateral wall became infrolateral wall. So this segment became infrolateral wall. Apical lateral and apical septum remained the same, but this become infrolateral and basal infrolateral walls. And when we cut a four-chamber view, cutting across the LV and RV, what we looked at? Anterior and lateral, that will become anterolateral wall. And inferior and septum becomes infroseptal wall. So this wall becomes apical inferior. It's not going to, apical septum. This is apical lateral. Apex did not change, but this becomes infroseptum, mid-infroseptum, or basal infroseptum. This is anterolateral and basal anterolateral wall. And this was trying to match with the nuclear scan people for reporting wall motion abnormalities. Same thing seen over here, now in different formats. And that's how we look at a bullseye pattern in these subset of populations. The problem did not remain the same. When we looked at these segments in two-dimensional stain, we were taking care of apical anterior septum and apical posterior wall also. More confusing. This is what we do majority of time in our center when we don't have any good imaging qualities. Now comes three dimensions ejection fractions. Not only looking at two dimensions, two chamber view, we look for three measurements from four chamber, three chamber, and two chamber views. And what we get end diastolic volume, end systolic volume, how much it's contracting, and the time of contraction. Last, the systolic function can be evaluated by myocardial performance index. We are going to talk about this later on, but let me give you a slip of this. The time interval between mitral closure and mitral opening is known as A. Left ventricular ejection time is known as B. If you divide A minus B, what is left behind is IVCT plus IVRT. If you divide this IVCT and IVRT by ejection time, you will get myocardial performance index. Normal is 0.46 or less than that. If it's more than 0.46, we call them as hypokinesis. And this is what is wall thickening abnormality is. And before I stop, let me show you a couple of examples of wall thickening abnormalities. And next class is just based on this. I hope you can see my slides. Look at this ECG. Poor progression R wave V1 to V4, 5, V6. Now look at the wall motion abnormalities. This is posterior wall. This is anterior septum. Now look carefully what is the problem with anterior septum. Even the basal anterior septum is not contracting. It's a basal and mid anterior septum. They're almost akinetic. Now look at the segments again. I can't tell you about lateral wall, but certainly the apex is akinetic. The mid septum is akinetic. Basal septum is also akinetic. Two chamber view. This is fine, but here apex, apical inferior, apical anterior, mid anterior, they are almost akinetic. So what we are looking for? LAD disease. And along with LAD disease, I'm looking at the septum also, which is almost thinned out akinetic. So not a single vessel disease, it's a dual vessel disease. And this is the amount of mitral regurgitations. Type 3 diastolic dysfunction. So the patient has got proximal LAD lesion because of the fact that this basal anterior septum is not contracting. Remember, when we talked about just a few minutes back, if the basal anterior septum is not contracting LAD, then we are possibly dealing with proximal LAD lesion. Same apex over here. Now, look, this basal anterior septum is contracting now. This is hypokinetic. Answer is distal to D1 branch of LAD. Very clear picture. Septum is doing well. Basal, middle apical. Apical lateral, mid lateral. Basal lateral is gone. Two chamber view. Nothing abnormal. Anterior as well as inferior wall. And if you go to three chamber view, mid and basal posterior wall is gone. So we are dealing with posterior or circumflex territory infarction. And here's the answer. We have an ST segment depression, lead to 3 AVF, V4, V5, V6. So that's all for today's classes. Now I'll call you upon questions, what you have in your mind. I should be able to reply those questions. This is like something when we started talking of vowels, peak gradients, mean gradients. It's virtually like this. Just a minute, I'm getting a paper. So, rule number 6, Rajan. Go ahead, Rajan.
सर हाइपोकाइनेसिस या कोई भी मूवमेंट एबनॉर्मलिटी के लिए हम देखते क्या है सर? जैसे
Endocardium?
मूवमेंट पूरे नहीं सर, एंडोकार्डियम देख रहे हैं, पर जो एंडोकार्डियम नहीं अगर हमें दिख रहा है तो हम उस सेगमेंट को एकाइनेटिक सेगमेंट बोलेंगे या हाइपोकाइनेटिक सेगमेंट बोल सकते हैं?
नहीं,
मतलब एंडोकार्डियम को नहीं देखना है, हमें मूवमेंट को देखना है केवल।
हमें सिर्फ एंडोकार्डियम को देखना है।
ओके, सिर्फ एंडोकार्डियम, ठीक सर।
Reason is,
यस सर।
Rajan, it's a very interesting question you have asked. Why? Heart is a dynamic structure.
यस सर।
It needs a very high frame rate. So what I've seen number of time people using ultrasound machine to do echocardiography.
यस सर।
Correct. And so much to so, sometimes they're using abdominal probe in doing echocardiography. When the frame rate is hardly 20. The picture I showed you a few minutes back, like especially that harmonic imaging, that is with a frame rate of almost 70 frames per second. So if you are using an echo machine, which is an ultrasound based machine for abdominal ultrasound, which is not a dynamic structures, what you'll see, you always report as global LV hypokinesis because you don't see endocardiums.
यस सर। ओके सर। फ्रेम रेट कितना रखना रहेगा सर?
At least 40 to 50.
ओके, थैंक यू सर।
And this is for people like who are reasonable weight, 70, 80, 60 kg weight. If the weight goes more than 100, you start finding nothing is seen because you don't see endocardium, you don't see any contraction, you report as hypokinesis, akinetic.
ओके सर,
All
थैंक यू
right.
सर। थैंक यू सर।
Anybody else? We'll be talking of systole, diastole, everything. Dr. Arya, row number 2.
Sir, good evening. Sir, my question is sometimes I have seen that in the report there are written that global hypokinesia. Sir, what is the meaning of global hypokinesia in case of ischemic heart disease and in case of heart failure, and how to differentiate it?
Good question. Global hypokinesia means all 16 segments, they are less contracted.
Yes, sir. But
This is like,
sir, how?
this is like an old balloon. And if it's ischemic, some segment will contract more, some segment will contract less. Allow me a minute. Let me just take out a recording from my armamentarium. Because echo is images, and once you see images again and again, then you will realize what is my echocardiography is. Now look at this picture. This segment, basal lateral wall, is contracting a little bit. Rest all virtually, they are not thickening. Look, this is movement. That somebody was asking me a few minutes back. Dr. Rajan Verma was asking what is motion, what is thickening. So this is thickening. This is some amount of thickening, and this is motion. There's no endocardial degeneration over here. I can't comment much on the apical segments. Why I can't comment? Because I don't see them. But LV looks to be dilated. When you see hypokinesis in virtually all segments, then you say that this is possibly the global LV hypokinesis. Now, same patient. Now, there's no second thought that this patient is ischemic heart disease subject. Let me just zoom it slide for you. Look, this is segment is almost akinetic. The some shows contraction over here. Some contraction seen over here. And not at your level. If I have to teach to level 2 levels, so what I always say is do a tissue Doppler imaging. This is S wave 3 septal, 3 lateral, 3 anterior, 4 inferior, and 4 posterior. All tissue Doppler waves are uniformly truncated. So possibly we are dealing with dilated cardiomyopathy. Let's try some more examples. Give me a sec. Now look at this subject. Normal, abnormal. This is still good. It's very difficult for you to differentiate in this picture. So let me just switch off this system. I'll switch on from go to other case. Yeah. I hope this will realize is a true patient of dilated cardiomyopathies. Now let me make it bigger for you again. Look, only this segment is contracting.
Sir, your screen is not visual.
It's not
Not
visible, sir. Yes.
visualized. Just give me a second. Is it visualized now?
Yes, sir.
Yes, sir.
Now see this segment. This is known as non-compaction. We'll be talking about this when we talk of cardiomyopathy. This is dilated LV, and look, there's only hardly any thickening over here. This is all sliding motion, as if something is sliding over the heart. And when you happen to see this, then possibly we think of dilated cardiomyopathy. I'll show you a few more pictures of this. Can you see this now? This is known as spongy myocardium, non-compaction. Many people, they give many names. And every year, new name will come. And this is a papillary muscle, cord or a papillary muscle which is hanging over here. And the first example which I showed you, that was ischemic cardiomyopathy. When you could see multiple layers of different, some were akinetic, some were hypokinetic, some were normokinetic. That is ischemic cardiomyopathy. Roll number 5, Dr. Debagna Adhikari. Go ahead, Dr. Debagna. No, Dr. Debagna is not there. This is online number 5. Just a minute. She is Dr. Anima Firdos.
Good evening, sir.
Good evening, Anima. I'm sorry, last time I missed you. I'm really sorry about it.
It's okay, sir. Thank you, sir. Sir, I have a question that how can we differentiate between dyskinesis and aneurysm as they both have bulged out segments?
Dyskinesis and aneurysm. Dyskinesis will always be bullet-shaped LV when the segment is bulging out. Aneurysm would be, the apex would be rounded in shape. Akinetic, dyskinetic segment will become aneurysmal. So if the apex is rounded, it's always aneurysmal. If its apex is triangular in shape, then fair chances are we are dealing with dyskinetic or akinetic segments.
Thank you, sir.
Thank you. How are you, Anima? Everything is good at Bangladesh?
Sir, more or less okay. We are dealing with this.
All right. Take care. All the best and stay safe. Take care of yourself and your family also. And take care of any other person who needs help. That's all I can say.
Thank you, sir. Please pray for us.
Sure. Always my prayers are with you. I have been there in Bangladesh since 2007. Many of my students, they have risen to NICT levels in the level of like professors. Just forgot the names. They are now professors in NICVDs. So my prayers are always with you and you should grow well. India has contributed a lot in the development of Bangladesh in last almost 71 onwards.
Yes, sir.
All right. Take care. Stay safe. Rule number 26.
Sir, good evening, sir. I'm Dr. Swami.
Yeah, Dr. Swami, go ahead.
Sir, how can we measure endocardial thickening, sir? Is it in systole and diastole difference? Or,
Measurement of endocardial thickness is always in diastole. Systole, they'll thicken. So normal thickness is up to 12 millimeters.
Sir.
Always in diastole.
So systolic thickening means 1.5 and 1.2 to 1.5.
So that thickening, when it becomes small, let me go back to my presentation. Just give me a second. Yeah, I can show you the thickening from here only. Wait a minute. That is like, we cannot measure it. We can just assess it visually by our eyes. Can you see the slides now?
Yes, sir.
Now look at this, focus on this basal lateral. This is basal inferior, anterior wall. This is lateral, basically some combination of anterior plus inferior, because I could see a papillary muscles. I could see some three RV over here. So this is possibly a basal lateral wall. Let me stop it for you. Correct. Now you measure this thickness from this point to this point. And this is in systole. So I'll go back a little bit to freeze at the level of, yeah. Now you measure this over here in early systole or beginning of systole from this point to this point. And then you move to mid systole. I'm trying to freeze my cycle at mid systole. Yeah, I'm at mid systole. Now you look at this red point over here. So
Yes.
then you measure the same segment over here if you really want to do it. But it's subjective. What we talk is subjective. We don't talk of objective because we cannot measure them. Look at this segment. It's not thickening at all.
Yes, sir.
This segment is also not thickening. It's motion. It's moving with the with systolic contraction, but it's not thickening. So that's what is more important to understand. Okay.
Okay, sir. Thank you, sir.
Dr. Tushar, 25.
Good evening, sir.
Good evening, Tushar.
Sir, in one slide you talked about some scores in which you gave 6 segment 3 scores and rest of the segment 1 score.
Correct.
And total score was 28. That I have not got, sir. What was
What
that?
exactly happening is some people, they ask you, what is my wall motion score index? So normal segment, let me get back to that presentation because once you see that, then you will get a better idea. I've touched this topic for the first time over here. Otherwise, I never used to touch it because some people asked this question last time. All right. So what is this? Once we have a normokinesis, we give you a score of 1. Hypokinesis, we give a score of 2. Akinesis, we give a score of 3. Dyskinesis, we give a score of 4. Aneurysm, we give a score of 5. Correct. Now, akinesis is 3. So the question is, if all segments are normokinetic, so 16 segment into 1 is 16 and divided by number of segments, 16. So score would be 1.
1.
Correct. Now
Yes.
look at this LED territory, 4 chamber view, apical septum, apical lateral along with apex akinetic. So 2 segments. 2 chamber view, apical inferior, apical interior, mid anterior along with apex are akinetic. 3 segments. And 3 chamber mid anterior septum along with apex akinetic. So between we are dealing with mid LED lesions. 1, 2, 3, 4, 5, 6. 6 segments akinetic means we have to give a score of 3.
So this was an example.
Yeah, I showed you an example.
Okay.
So this is 3 segments are akinetic, 6 segments are akinetic. So 6 into 3 becomes 18. Now
Yes.
10 segments are remaining behind, which remains normal. So we give them 10 into 1, 10. 18 plus 10 becomes 28. And these 28 number has to be divided by number of segments, that is 16. The score becomes 1.75.
More the score, more bad it is.
Correct. And based
Okay.
on this score, we really prognosticate. Allow me a second. I'll show you like how do we prognosticate subjects. Just a minute. Everything has got a certain definite values of evaluations. Yeah. Can you see the slides now?
Yes, sir.
So this is event-free survival based on the scores. So as the scores move up and up, the function or the longevity or event-free survival goes down dramatically. So that's one way to give like what is like my ultimate outcome is. Suppose my score is 1.75. It means in that 6 segments, my heart is not contracting. And this is very true when we are doing a stress echocardiography. Suppose my resting score is 1 and it's become 1.75. So I'm very worried that this patient is not going to do good if we do not take for interventions.
Yes, sir.
That's how it behaves. Okay.
Yes,
All
sir.
right. So let's move on to roll number 7. 7 is Dr. Webb, Parveen Tasir.
Good evening, sir.
Good evening, Parveen.
Sir, my first question is for the aneurysm to say apex in bulletin shape apical 4 chamber. So, in same concept applied in apical 3 or 2 chamber, sir.
Exactly.
Yes, sir. And
Heart is a globular structure. Heart is not a like slice of a bread. When the apex will dilate in all segments. It's very unlikely the apex. Look, if you look carefully, what is the territory of apex territory is?
apex is LED.
LED. So can you expect even if a distal LED there, if the segment becomes akinetic, it has to be through and through.
Yes, sir. And second question, sir, for akinesia and hypokinesia. Sir, can you explain with respect to endocardial thickening and movement again, sir? I still don't get it, sir.
Okay, no issues. As many time as possible. I'll go back to my first slide because that has got everything into it. Can you see the slides?
Yes, sir.
All right. Good. Hypokinesis means less contraction. Akinesis means poor contraction. Normokinesis is more than 50% of contracting. Now, this slide shows there is no contraction in this mid and basal septum. This is normally contracting. This is hypokinetic. Now, see carefully. No thickening, no endocardium seen. Some endocardium seen which thickens. Some endocardium seen which thickens. This is almost akinetic, but endocardium is seen. Here, endocardium has become scarred. So everything is seen in this slide. This looks to be
Sir,
relatively better thickness than rest of the segments.
sir,
Lateral
this
wall is
more,
appears to be better
sorry.
thickening. This is better thickening.
Sir, this more white is myocardium, less white is endocardium, sir. Like
More it is
hyperintensive.
not. I don't say that. I'll say, now I'll just this point out. Now I'll freeze over here. Look, this is myocardium and this is all endocardium here. Now see carefully. This part which is thickening is endocardium. This part is endocardium. This part is myocardium. If you do not see endocardium, then what you see? You see only myocardium, and then we see global LV hypokinesis. You only see this part with poor echo machines. Okay?
Uh, 1 second, sir. So if endocardium become thick and the segment come inside the LV cavity means normokinesis.
Correct.
And if endocardium like thick but less thicken and segment not moving properly is hypokinetic.
Correct.
And there is no endocardium and no movement means no movement inside the LV cavity, that is
But
akinetic.
endocardium is seen, but there is no thickening, means akinetic. Look, endocardium is seen, but it's not thickening. No endocardium seen,
Yes,
no thickening, there's scarred tissue.
yes, sir. Thank you, sir.
All right, anybody else?